It is really an honor for me to speak here. And Dr. Kaiser, your support for this course from the beginning has been instrumental in making this a success. And thank you for your ongoing support. These are my disclosures. And even though I had a lot of role in deciding on the sequence of lectures, I put myself between two amazing speakers. So next year I'm going to do a better job, but I'm going to try to rise a little bit to their level. But I'm going to try to lighten up the mood first by telling a joke. So an oncologist, a surgeon, and a gastroenterologist walk into a Las Vegas magic show, and the magician promised to make something disappear. So the oncologist says, "Can you make cancer disappear?" And the surgeon asks, "Can you make my stress disappear?" Yeah, especially with seeing Dr. Fakih's talk, and surgery is not going to be done in many patients. And then the gastroenterologist says, "Well, just make sure whatever disappears doesn't end up in the colon because I'm on call." So I'm going to talk about the role of endoscopy in rectal cancer, and this is an area that's really rapidly evolving, mostly because of our medical oncologists' work who keep changing the paradigm, and now the paradigm can be changing every 6 months. I'll be touching on diagnosis, staging, assessment of tumor response, surveillance, resection and ablation, and I'll try to give you some pearls, again, because the field is changing rapidly. Some of these might not have as much data as we would like. I'm going to start by talking about some statistics. There are 15,000 gastroenterologists in the United States and 45,000 rectal cancer that are diagnosed yearly. So really most gastroenterologists only occasionally see rectal cancer. So I want you all to keep that in mind. And be kind when you have a gastroenterologist who referred you a patient with rectal cancer and they didn't do the right thing. Remember, you're at an opportunity to help two people, the referring gastroenterologist and the patient. So often in my practice, patients ask, "Well, why didn't they tattoo? Why didn't they do this?" I'm like, they did their job. Their job was to diagnose you. Now you're in a cancer center. And then we have to do more stuff, including repeating your endoscopy. So that's pearl number one, be kind to the referring doc. And now, when we talk about diagnosis, it's no longer taking a biopsy and getting a diagnosis. So pearl number two is communication. It's very important what is done at your center. So you need to talk to your medical oncologist, you need to talk to your surgeon. What is really that they're looking at you to do as a gastroenterologist to really become a good member of the multidisciplinary team. So diagnosis is often more than just diagnosing the cancer. It's diagnosing the genomic profile, which genomic testing are they using, is it tumor informed, is it tumor not informed, how much tissue do they need, and then how do you process the tissue, where do you send it. So it's a little more complicated than the good old days. You take a biopsy or you walk out, say, I tell the patient I have cancer. There are all of these questions that now come up. Is it microsatellite stable, microsatellite unstable? Which, as a gastroenterologist, if you can facilitate this acquisition, you make the flow of the patient better. Tattoo, not tattoo, all these, it is very dependent on the surgeon's preference. And I cannot give you a recommendation how to tattoo. What the recommendation is, talk to your surgeon and make sure what you're doing is contributing to their work and not making their work harder. Staging, and the NCCN guidelines favor MRI over endoscopic ultrasound, so keep that in mind, especially for bulky disease and advanced lesions. When you read, however, the NCCN guidelines, even though they say recent studies, they're quoting studies from 20 and 30 years ago, from very old technology. And I'll show you some pictures today. EUS is changing, and EUS will be changing rapidly in the next couple of years. The biggest pearl I can give you here, though, is that staging is still not done appropriately on the majority of patients. In a study that looked at over 1,000 rectal cancer patients that were diagnosed, and we're doing a slightly better job, but less than 40% in 2016 had complete staging, and around 50% 3 years later had complete staging. So we're heading in the right direction, but we still have a lot of room to go. And staging is really key in determining prognosis, in determining whether patients qualify for clinical trials, and determining response to tumor. So it's very important not to understage or overstage. I want to tell you that US still plays a role, especially when you have a specific question you want to answer. The resolution of US is still superior to MRI, so we've had a lot of discordance between MRI and US, especially when it's very subtle. You see on the right side of the image the resolution of US, and this image is actually not the technology that's coming up in the future. Soon we will have 3D US, like you see here. This is an image from the bottom. These are images from Europe. In my opinion, the biggest barrier to US quality is actually the inability of the surgeon to scroll through the images, because they have to rely on the gastroenterologist's interpretation. They have to look at these, different shades of gray and images that show up tiny on the electronic medical record. So as this and it's going to be coming soon to the United States, it's currently available in Europe, I think the role of the US might change, and this will need further research. Now, when it comes to assessment of tumor response, we're really looking mostly at the patients who've had a complete clinical response, and endoscopy continues to be one of the gold standard in this area. And sometimes you need a biopsy, sometimes you do not need a biopsy. I know we will see some images in the next talk about how to really assess that. So I'm not going to dwell too much on it. But an important question to know, especially for gastroenterologists in the audience, is when do you assess for complete clinical response in the era of TNT, or total neoadjuvant therapy? For patients who are treated with chemotherapy first, followed by radiation, the assessment should be performed around 8 weeks after the completion of radiation. For patients who receive radiation first, followed by chemotherapy, it's around 4 weeks after the completion of treatment. Now, I'm going to move to surveillance, which is really a big bulk of what gastroenterologists do today in cancer centers. Because if you look at the number of surveillance that are needed on average, is around 16 endoscopies in 5 years, which is what's recommended in patients who have a complete clinical response, or in patients who have high risk for local recurrence. Who are the patients today who have high risk for local recurrence? It's patients who do not have a lymphadenectomy, essentially, because even though we want to think that we are very accurate in staging, these are still people who do not have a complete cancer surgery because you don't have a good assessment of the lymph nodes. Will that change with circulating tumor DNA? We're going to hear a talk tomorrow about this. And then, so today the patients who are at high risk for local recurrence are patients who have no lymphadenectomy, so transvaginal excision, endoscopic resection, whether endoscopic submucosal resection or endoscopic submucosal dissection. And then in patients who have complete clinical response who are not managed non-surgically, which is becoming a larger and larger number of patients. What is recommended? It's EUS or pelvic MRI with contrast every 3 to 6 months for 2 years, and then every 6 months for 5 years. It depends on the study you look at. Some studies show that over 98% of patients can be caught in this. However, there are some studies showing that 25% of patients recur locally after 5 years. So I think you have to keep an open mind when you're doing surveillance for these high-risk patients. The key here is communication. Who's doing what? Because these are patients who require intensive surveillance. As Dr. Cole said, if the guidelines say you have to do this often and you're not doing it, and the patient recurs and has a bad outcome, you have to be able to defend that. So I highly recommend very intensive communication in these settings. EUS continues to play, however, a big role in surveillance, and mostly because of the ability to get tissue that is more than from the surface or the mucosa. Here's a patient, for example, who had declined surgery and initially appeared to be responding but did not have a complete response. And the patient declined surgery unless they have a proof of residual cancer. And so on the mucosal biopsies, the biopsies were negative. So often, and I see head shaking here, often the patients say, no, I don't want to have surgery. Even though we know the imaging is enough by criteria and from experience that this patient still has cancer. This is an area where EUS is still very helpful. For example, this patient had deeper, you'll see the needle going through the tumor, and the biopsies were negative, even though endoscopic biopsies with mucosal biopsy with sigmoidoscopy were negative. We sometimes use elastography. This is a technology available in endoscopic ultrasound to show you the stiffness of the tumor, but this is still honestly in the research realm. So we always use it, but we're more using it to learn than to guide our practice. Now, as I said, circulating tumor DNA might change this paradigm, and 6 months from now we might be talking a different conversation. In GI ASCO this year, a study was presented that showed that ctDNA positive after surgery or after complete clinical response predicts recurrence with a very high chance of recurrence. And in patients whose ctDNA turn negative and then turns back positive, ctDNA turns positive on average around 10 months before clinical diagnosis, so whether MRI turns positive or US or biopsies. So keep that in mind. The NCCN guidelines have not adopted yet ctDNA, but I think this is coming. The question is not if, the question is when. And then what else can we offer with endoscopy? Resection, whether endoscopic mucosal resection, which is basically grabbing a lasso and putting it around the cancer and resecting it, which for small cancers can be en bloc, but for polyps that we don't know there's cancer ahead of time, it could end up piecemeal, and these patients often need surgery, or endoscopic submucosal dissection, which is a more advanced technique that is able to resect en bloc larger tissue sizes, really unlimited tissue sizes in good hands, and will give you an adequate pathologic assessment of the resection and with pathologists who are experienced in that. ESD, however, continues to be limited and not available in all centers in the United States because it's highly technical. But again, the advantages are no limit on size, en bloc resection. It is organ preserving, so patients often do not have any significant symptoms after resection with endoscopic submucosal dissection. And then the key, as I said, sometimes you resect the polyp, you don't realize it has cancer, is learning the assessment of surface pattern, which correlates with the depths of invasion, and then that allows you to have good selection of patients who can have endoscopic resection, or the patients who you just put through the risk of endoscopic resection and they still require surgery. Anyway, so that's key to keep in mind with endoscopic submucosal dissection. What are the criteria for curative resection with endoscopic submucosal dissection? So negative circumferential and deep margin, submucosal invasion with depth limited to less than 1,000 microns. So really, the way you preserve the tissue, the way you give it to the pathologist is very important, and a pathologist who understands this resection. In addition to the absence of lymphovascular invasion, advanced tumor budding, or poorly differentiated tumor. Overall, the risk of lymph node metastasis after curative resection is in the 3 to 6%. Will circulating tumor DNA play a role in this, in selecting who goes to surgery or not? This is to be determined. This is definitely something that is being studied. And if you do a local, incomplete cancer resection with no lymphadenopathy, whether it's done surgically or endoscopically, the outcomes from poor quality data seem to suggest that the outcomes are similar. So which modality is used is really center dependent and depends on the local expertise. Now, this is one of my favorite topics, and I'm so glad we have so many of the technologies that are focused on cancer ablation here to marry medtech and other modalities and have endoscopy join multimodality cancer therapy is endoscopic cancer ablation. And this is still overall in the research realm. Today we have many modalities that are available. In GI ASCO, local therapies were a big thing this year. So cancer ablation fits under that. With endoscopic cancer ablation, the advantages are the fact that it's safe, it's easy, and it gives you the ability to assess your tumor response, to get biopsies if you want, and it can be repeated. That's probably the biggest advantage for endoscopic cancer ablation. One reason where I feel cancer ablation will play a role in the future of cancer care, one is medical oncologists are focused on organ preservation, so trying to figure out how not to alter the GI tract. Because when the GI tract is altered, especially in the rectum or the esophagus, the quality of life overall is not great. The two factors I think contribute to the growth of cancer ablation. The fact that the cancer heterogeneity is larger in the primary tumor than in the lymph nodes and in the mets. This is a study that looked at that, and if you look at colorectal cancer, it sits somewhere in the middle. So there is more diversity in the local tumor than the lymph nodes than the mets. So in the response to systemic therapy, sometimes you'll see a residual local tumor where you need to augment the therapy, which is, surgery is one form of cancer ablation, radiation is another form of cancer ablation. The other issue is that the tumor microenvironment dictates the response to therapy, at least partially. So tumors in the liver can respond differently than tumors in the lung, than tumors in the rectum. And ablation is going to work differently in all of these organs. All of these still need to be studied, and all of these are more in the realm of asking questions than having answers. And the holy grail for us endoscopists or anyone who does procedure is, can we help Dr. Faqih in a tumor that is not responding to immunotherapy, turn a cold tumor into a hot tumor and respond to immunotherapy? The advantage for endoscopy here is the fact that it's safe and can be repeated. So a couple areas where endoscopic ablation is currently being used. One is in patients who decline surgery, especially after total neoadjuvant therapy. This is a patient that we started doing this, but we're mostly interested in research on this. But this is a patient 2 years ago that refused surgery, had TNT, and had a complete clinical response. And now 7 months later, he recurred. And by staging, he was what we call low risk T3. And because he declined surgery, we offered him cryoablation. He actually came asking for cryoablation. And after 4 sessions, the patient had a complete clinical response, and he's still in surveillance now for 2 years without recurrence, including no evidence of tumor on ctDNA. Again, this is not something we recommend, but this is something we recommend to study, and we'll be starting research on this. Another area that we're looking into ablation is in the realm of palliation. This is, for example, a patient who's 77 years of age, who had a history of multiple cancers, including ovarian cancer and right colon cancer, and had resection and presented with a mass in the sigmoid with obstructive symptoms. The patient was seen by 3 surgeons who deemed her a non-surgical candidate because of complex abdomen and multiple prior surgeries. And in most cases, this patient would receive a stent for her obstructive symptoms, but we all know stents are not ideal. We offered this patient pulse electrical field ablation. This is a modality that it's a needle-based. I classify ablations into mucosal ablations and then transmural ablation. This is a transmural ablation. And you can see here the field of ablation. After using it, this is done by endoscopic ultrasound. And here's a video. Here's a video of the procedure. We're measuring the tumor, and this is a needle via endoscopic ultrasound. And we have kind of guidelines as to how far you want to be from the mucosal surface. And these are the changes you see with ablation. One of the exciting areas about this technology is there's some animal data that you have a more response if you combine it with immunotherapy, again, in the spirit of multimodality therapy. This patient had resolution of her obstructive symptoms after two weeks after ablation. So in summary, endoscopy continues to play a large role in rectal cancer. The paradigm is changing. There are some areas where we see endoscopy playing less of a role in the future, where there are some areas where we see endoscopy might be playing a bigger role. And this is an area that is primed for research and innovation. Thank you.